Today we're beginning with intestinal obstruction. Intestinal obstruction is defined as a significant impairment or complete arrest of the passage of contents through the intestines. Symptoms include abdominal pain, and it's typically described as a cramping type pain, vomiting, obstipation, as well as lack of flatus or gas. Etiologies for intestinal obstruction. The most common ones are adhesions, hernias, and tumors. Other etiologies include items like diverticulitis, foreign bodies, volvulus, intussusception, as well as fecal impaction. Now, with the presence of mechanical obstructions, these are divided into obstructions of the small bowel and obstructions of the large bowel in terms of classifications. Now, obstructions are further classified as either partial or complete. A partial obstruction, in fact, most of those do not require surgery, while most complete obstructions do. Obstructions may be simple or strangulating. Simple obstructions are those obstructions that do not compromise the intestinal blood supply. Strangulating obstructions, they compromise the intestinal blood supply. Please note, when it comes to these two forms, simple obstructions typically do not require surgery, whereas strangulating obstructions do require surgery. Now, with small bowel obstructions, what's typically seen is that symptoms are produced very shortly after the onset of the obstruction. With symptoms and signs of small bowel obstruction, we typically have the presentation of abdominal cramps that will be centered around the umbilicus or the epigastrium. They typically can have problems and complain about vomiting. The subsequent development of obstipation in those patients with a complete obstruction, and typically diarrhea, or they may have diarrhea in patients with a partial obstruction. If these patients have the presence or the development of severe steady pain, that's suggesting a strangulation presentation. Also, with these individuals, the presence of hyperactive, high-pitched peristalsis that's coinciding with the cramping is very typical, so they may have borborygmi present with this. Now, with large bowel obstructions, typically we're going to see a milder symptom presentation than with obstruction of the small bowel. The symptoms associated with large bowel obstruction tend to develop more gradually. So, going back to looking at the physiology of the GI tract, keep in mind we're going to have more contents or a larger volume within the small intestine because absorption is occurring through the small intestine. Therefore, symptoms come on more rapidly. By time you have an obstruction develop within the large intestine, all the normal functions have occurred with the small intestinal tract, all the absorption, all that's left within the large intestine then is going to be water as well as waste material. So it's seen that the symptoms tend to come on a little more mildly or slower, if you will, because you've got less volume. Etiologies for large bowel obstructions include tumors, diverticulitis, volvulus, as well as fecal impaction. These are the most common etiologies. Now, when it comes to tumors, most of these will occur at the splenic flexure and the sigmoid flexure. With diverticulitis, most of these occur at the sigmoid colon. Volvulus, where we have twisting of the bowel, the most common site is again in the sigmoid colon. Symptoms and signs include increasing constipation that leads to obstipation, and then subsequent abdominal distension. Vomiting is another symptom. It may occur. If it does, though, it's going to usually show up several hours after the onset of the other symptoms, and this is not a common symptom that develops. Patients will report lower abdominal cramping present. On exam, though, a lot of times there's not palpable abdominal tenderness. Loud borborygmi present during auscultation. On palpation as well, during exam, a mass at the site of the obstruction may be palpable. Patients will report symptomatology of left lower quadrant or left upper quadrant pain, and this makes sense in terms of where the obstruction would occur. Keep in mind, on the left side of the colon, this is where the semi-solid fecal material is being stored, and this is the most likely area of involvement for an obstruction to develop in the large intestines. X-ray will often show, or typically show, a bird beak deformity in the presence of an obstruction. And this is where the proximal part of the GI tract becomes distended, and the distal part is going to collapse due to changes in pressure. See the example on the next slide. Ischemic colitis, also known as mesenteric colitis. Acute mesenteric ischemia is the interruption of intestinal blood flow by embolism, thrombosis, or low blood flow. This presentation leads to inflammation, and ultimately infarction develops. So the symptoms and signs include abdominal pain as well as loose stools and diarrhea. Please note, with this condition, the abdominal pain is really out of proportion to the physical findings. There's not a whole lot in the way of initial physical exam findings, so early diagnosis is very difficult for this condition. The patients will typically complain about the pain being present in the left lower quadrant. With the development of loose stools and/or diarrhea, there's often the presence of expelled blood clots within the fecal material. One thing that can be found on physical exam is the presence of abdominal tenderness. But think about all the conditions we've already talked about that have abdominal tenderness. So it's not pathognomonic just for this presentation. This condition will commonly affect people in the 6th to 8th decade of life. Barium enema X-ray, will show what's identified as thumb printing, and this is considered to be diagnostic of ischemic colitis. Here's an example of thumb printing on a transverse colon. The area has been circled for you to focus in on. Here's another example of thumb printing. So, with chronic abdominal pain, and this condition may be abbreviated as CAP, this is pain that persists for more than 3 months, and it's either continuously or it's intermittent. Now, intermittent pain may be referred to as recurrent abdominal pain that's abbreviated as RAP, R-A-P. Now, chronic abdominal pain may occur at any time after the age of 5, and nearly all patients that have been diagnosed with chronic abdominal pain, they have had prior medical evaluation, and that did not yield a diagnosis after completion of the history, physical, and basic testing. Now, chronic abdominal pain patients can have physiologic causes that can actually persist for more than 6 months without the presence of evidence of any physiologic disease. We can also see that the pain can show no relationship specifically to items like meals, defecations, in female menses, etc. So at this point, these conditions may actually be associated with hypersensitivity of the nervous system at the spinal cord level. So here's a brief introduction on some information regarding the average American diet. So the average diet in the United States is high in refined carbohydrates, saturated fats, processed foods, and cholesterol. It's low in dietary fiber in general. Food manufacturers spend over $4 billion annually to advertise food in the United States. Now, when it comes to dietary fiber, this is found in plants. The plant cell wall typically contains about 35% cellulose and about 45% non-cellulose polysaccharides. Now, when we look at cellulose, it's relatively insoluble in water. It has the ability, though, to bind water to it, which accounts for its effects of increasing fecal size, as well as weight, and promoting regular bowel movements. Cellulose cannot be digested by humans, but it can be partially digested by the bacteria that's found in the large intestines. And this natural fermentation process, it results in about 50% breakdown in the cellulose. So when we look at fiber in general, it has long been used in the treatment of constipation and diarrhea. So fiber, it helps to slow down transit time and it acts to normalize bowel movements. It helps to make the bowels bulkier, and it also then stimulates water to be pulled into the bowels to soften it, lubricate it, make it easier to move along the colon, and with that it's going to enlarge the bulk of the fecal material, and it's going to stimulate peristaltic activity, so it's going to make it easier to move in the colon, and it requires less pressure to defecate, so there's less straining at the stool, which is going to decrease things like hemorrhoid development and diverticulosis development in the colon. Dietary fiber also helps to slow gastric or stomach emptying, and this results in food being released more gradually into the small intestines, and it helps to better control glucose regulation. Dietary fiber also plays a role in the maintenance of suitable bacteria in the colon. It helps to keep the lactobacillus guys present and growing. It also restricts the overgrowth of endotoxin-producing bacteria, which are the bad form of bacteria. Also, there's been some interesting population studies as well as clinical and experimental data that shows that diabetes mellitus is one of the diseases that seems to be most clearly related to a low fiber diet. Also, high fiber diets help to prevent or minimize colorectal cancer.